Hello, everyone. So, just to give a brief introduction, I get nervous at public speaking. I'm already country and talk fast, so please raise your hand if I start speaking a little fast, okay? I was a kid growing up where your parents had to drag you in church when I had to do my Easter speeches and Christmas plays. That was crying, that was me, so. So I'm going to be doing a talk on metabolic dysfunction associated steatotic liver disease. So, the overarching term, steatotic liver disease, was chosen to classify individuals with hepatic steatosis due to various etiologies. The Delphi criteria they met because they thought the term fatty liver was a little bit stigmatizing and condescending, so they came up with a new vocabulary to help with this. So the overarching term encompasses MASLD, which stands for metabolic dysfunction associated steatotic liver disease. And it includes people with cardiometabolic risk factors and a spectrum of alcohol consumption. So if they have alcohol consumption associated with metabolic dysfunction, it's called metabolic dysfunction and alcoholic associated steatotic liver disease. And then there's also, your classifications of drug-induced liver injuries, which we call daily and cryptogenic and other causes of liver disease. So this is just going to be a brief breakdown of how they did it. So here we have metabolic dysfunction associated steatotic liver disease, which is called MASLD. So under MASLD, you can have steatotic liver disease without any inflammation, or you can have MASH, which is metabolic dysfunction associated steatohepatitis, which is when you have the biopsy and they had inflammation noted on biopsy results. We don't have to do biopsies for this anymore, but those are just the two terms that are under it. So when you get the metabolic dysfunction and alcohol-associated liver disease, this is kind of how you classify more towards MASLD versus predominant alcoholic-associated liver disease. So if a woman drinks more than 140 grams of alcohol weekly and a male 210, that still would be considered the combination of the metabolic and alcoholic-associated liver disease. But if you get closer to the drinking, as a female, 350 grams a week, and as a male, 420 grams a week, you get more of the, likely more alcoholic reason that's causing their fatty liver disease. So you want to make sure you do alcohol cessation with those patients. And then just we have our regular categories that we deal with. You guys don't really have to worry about, but like drug-induced liver injuries, like for a lot of people on statins, things like that, your monogenic diseases, cryptogenic, and your autoimmune disorders. So some of the criteria to define MASLD. So most people get ultrasounds and they say they have like hepatic steatosis or they say fatty liver. So if they have that on imaging and any cardiometabolic risk factor, it would confer a diagnosis of MASLD. Like I said, in the case of alcohol, this is defined as metabolic dysfunction and alcohol-associated liver disease, or if it's just strictly because they're drinking so much, it's alcoholic liver disease, depending, like I said, on that prior chart of how much alcohol they're drinking. So they only have to meet one of the 5 criteria. So if they have a BMI greater than 25, or if you're of Asian descent and it's greater than 23, or if they have a waist circumference greater than 94 centimeters as a male, or greater than 80 centimeters as a female, or if they have a fasting glucose greater than 100 milligrams per deciliter, or if they have a 2-hour post-load glucose level that's greater than 140 milligrams per deciliter, or anyone with a hemoglobin A1C that's greater than 5.7%, or anyone who's a type 2 diabetic, and anyone that's on any treatment for diabetes regardless. Also, if anyone who has a blood pressure greater than 130 over 85, or anybody on any antihypertensive medications, and people who have elevated triglycerides that are greater than 150 are on any statin or lipid-lowering treatment, and people who have a low HDL, less than 40 for males, less than 50 for females. So you only have to meet, have the finding of hepatic steatosis on ultrasound or any imaging that you had done in any one of those criteria. So if you have a clinical suspicion for steatotic liver disease, so you had a patient who came in imaging, had hepatic steatosis, and they already have metabolic risk factors, and they had like mild elevation of their liver enzymes, they should undergo further evaluation. And for further evaluation, we do the fib. So what's next? So, and you guys, you see these patients all the time. You want to exclude advanced fibrosis with using a test with high negative predictor value, and that's going to be your FIB-4 calculation. So when the FIB-4 is less than 1.3, patients can be followed in a primary care setting and reassessed periodically. So patients with prediabetes and less than, patients without prediabetes and no type 2 diabetes and less than 2 metabolic risk factors, you can do a FIB-4 on these patients every 2 to 3 years. Patients with prediabetes, diabetes, or 2 or more metabolic risk factors, they should be more frequent at FIB-4, so you can do it every 1 to 2 years, but probably every year would be better. And then in patients older than age 65, a FIB-4 cutoff of greater than 2 should be used. So just some reminders about FIB-4. It has a low accuracy in individuals under the age of 35 years old. So you should do secondary assessment, and I'll talk about that a little bit later. But you want to look at their metabolic risk factors as well, and if they have elevated liver enzymes, but I go more into detail about that. And of course, FIB-4 should not be used in anyone that's acutely ill, because it can make the numbers be inaccurate. So you did a FIB-4, and now it's greater than 1.3. Do I need to refer to GI? The answer is no, you do not. So now I'm going to be talking about the secondary assessment. So anyone who has a FIB-4 greater than 1.3, a secondary assessment should be done, preferably with a vibration-controlled transient elastography, but unfortunately we do not have that. That's a FibroScan. But we're in the works of getting a FibroScan machine, so hopefully within the next few months you'll better get it ordered on Epic. We put out a big notification once we get the machine. But what I typically use in clinic, I use the enhanced liver fibrosis testing. It's a lab, but I'll talk about that in a couple of minutes. But if you have a patient who has a FIB-4 that's greater than 2.67, and they can see, or they have like elevated liver enzymes for more than 6 months, you want to consider referral to gastroenterology for further workup and evaluation to rule out any other causes of liver disease. So with the FibroScan, if you have the elastase score that's less than 8, that's usually low risk. So these patients, if they have diabetes or more than 2 metabolic risk factors, you want to make sure you repeat a FibroScan every 1 to 2 years. In patients who do not have type 2 diabetes and less than 2 cardiometabolic risk factors, you want to do a FibroScan, send them every 2 to 3 years. And anyone who has a vibration score between 8 and 12, they're considered intermediate risk for advancing to fibrosis. So you want to start these people on treatment and repeat FibroScan in 1 year to see how they're reacting to the treatment. And I'll go over treatment options a little later in the presentation. Anyone with a vibration score higher than 12, these people are high risk. They likely have advanced fibrosis. So you want to send them to GI to see if they need any additional testing versus biopsy. People don't do biopsy anymore. You can kind of tell if people have cirrhosis based off platelet count, evidence of portal hypertension, things like that. Oh, so I went backwards. So as far as the advanced liver fibrosis testing, it's kind of the same thing with the FibroScans. So you want to check it every 1 to 2 years in patients with diabetes or 2 or more than cardiometabolic risk factors. If they don't have any risk factors, you want to do a FIB-4 on them at least every 2 to 3 years. If they have an intermediate risk, which if the F testing comes back between 7.7 and 9.8, you want to do treatment. And then, like I said, repeat the FibroScan yearly to see how the treatment, if it's working or not. And again, if it's greater than 9.8, these people have high likely chance of fibrosis, so you refer them for further workup. So how to order F testing? It's a LabCorp send out, so you can make a smart phrase. This is actually my smart phrase that I put into Epic. So you go into miscellaneous lab orders, and then you type in enhanced liver fibrosis F testing, and the test 6-digit number is 550659. I put the CP code in there too, just to make sure like I don't miss anything, but typically you just need the first 2. Just type in the name of the test, and you put in the test number and the test number when you do your miscellaneous lab order. So, of course, as you know, patients at all stages of liver disease, so how they do it is F1 to F4. F1 is mild, F2, F3 is where you want to kind of consider treatment, and then F4, they have a highly chance of fibrosis, so these people you refer to GI. But the main, you want to also make sure you counsel these patients on lifestyle modifications, because as we know, MASLD is a metabolic disorder. So you want to make sure that they lose weight, you get their diabetes under control, you get their lipids under control, get their blood pressure under control, because all these things, in addition to treatment, will help improve them. So this is this algorithm that I took from one of our guidelines here, just kind of summarizing everything I did. So it's the FIB-4 greater than 1.3. If it's not, you do a FIB-4, like I said, every 1 to 2 years. If they have diabetes, 2 to 3 years. If they don't, if they do have FIB-4 greater than 1.3, is it greater than 2.67? You can consider a referral. You don't necessarily have to. It's only if they had elevated liver enzymes more than 6 months, you can refer them to us, but it's nothing you have to do. And then this is just a summary of everything I had previously with the numbers like treatment versus no treatment referral. So then we're going to go into treatment options. So like I said, first thing is lifestyle modifications. You want to make sure that you do a slow weight loss in these patients, no more than 1 to 2 pounds per week, with an initial goal of losing 10% of the current body goals. And then you want to make sure that you treat any abnormal lipid and glucose levels. And then if sleep apnea is present, it should be treated as well, because we know sleep apnea can kind of has a relationship with MASLD as well. The reason why you don't want to lose more than 1 to 2 pounds per week, because they have increased risk of getting gallstones and end up getting cholecystitis like that. So that's like a safe amount to lose weight a week without further causing any biliary complications. So here's what I tell my patients. I say activity at least 20 to 30 minutes daily. And I say like high heart rate, getting your heart rate up, no like casual walking, like in the yard. I mean, you need to be like speed walking, getting a little shorter breath. And there's been studies showing that a Mediterranean diet is kind of the best for these patients, avoiding like red meat because it's more healthy with chicken, fish, more legumes, whole grains, stuff like that. That's typically the diet I recommend for my patients. So this is a study. So with fibrosis, it's been shown with people who have a weight loss greater than 10% have improvement of their fibrosis, but of patients doing this, less than 10% of patients are able to do this within a year. So we know they need some assistance. We know if you have a weight loss greater than 7%, it increases, this is the old guideline, so it should say MASH, but you have resolution in 64 to 90% of people, but like I said, only 18% of these people are able to reach it within a year. And then this is this ballooning inflammation. They should do biopsies that you would see associated with it. If you have a weight loss of greater than 5%, it had improvement of the inflammation that you see in the liver, but only 30% of people are able to meet this goal within 1 year. And just to get rid of the steatosis, which is the more kind of micro ballooning that we see on biopsy, a weight loss of greater than 3% improved it in 3,500% of patients. So this is treatments. Wegovy, it has to be Wegovy, all right? Wegovy saves everybody, as we know, with metabolic risk factors. So they did the Essence trials, and it had accelerated approval in August of this past year for treating MASH with moderate to advanced fibrosis. It's the F2 to F3 phase. That's following that intermediate phase on the previous guidelines. So people were on a dose of 2.4 milligrams per week for 72 weeks. And it improved both resolution of MASH without worsening fibrosis, and 62.9% versus the placebo of 34.3%. And it had a stage reduction in liver fibrosis without worsening of their inflammation noted on biopsies. So the final approval is still awaiting, but if you have any patients with MASH, they will get approved for Wegovy, like their insurance will pay for it. So treatments, the patients you want to treat, they should have MASH with stage 2 or 3 fibrosis, which is identified on your FibroScan, who have a vibration score between 8 and 15 kilopascals, are people who get an MR elastography, which we don't do here, but that range would be 3.1 to 4.4. Are people who had their F-lab blood work come back, and it's between 9.2 and 10.5. Guys, like I said, we kind of moved away from liver biopsies because they're unnecessary. We have these new non-invasive tests, which are less invasive and less complications. So it's in people who have like elevated, more like the F4 fibrosis, where you see who have a vibration score greater than 15, MRI elastography greater than 4.4, or F testing that's greater than 10.5. You kind of want to talk about it because really these people have more fibrosis, which is less reversible. And if they have any evidence of cirrhosis with portal hypertension, platelets less than 150, these people probably won't do well for treatment. So these people more likely have cirrhosis, so you don't necessarily treat them with any Wegovy. So when they did the study, it showed a favorable safety profile in the ESSENCE trial. There were no really elevation of liver enzymes. They recommend routine hepatic panels if concerned, but usually people are checking up once a year. As we know from GLP-1s, the most common events are all GI related, so nausea, diarrhea, constipation, vomiting, gastroparesis. And then you should monitor for the serious side effects, pancreatitis, cholecystitis, thyroid C-cell tumors, retinopathy progression, and people lose muscle mass when they're on these agents as well. So you just want to kind of make sure you're monitoring and making sure they're not getting the adverse events associated with the Wegovy use. So like I mentioned previously, lifestyle modification remains the cornerstone of management along when they take in the Wegovy. So you have to make sure they're still doing everything correctly, exercising, changing their diet. See, they didn't use really biopsies, but they used a non-invasive testing to do the study. But it did show that significant improvement at 72 weeks with people with MASH disorders. So the ALT came down by more than 17 points. The CAP score greater than 20%. The CAP score greater than 30%, and fibrosis improvement on FibroScan was noted. If you have no response, so when you do the FibroScan in a year, you kind of want to discuss with the patient, like if it's necessary to continue this, or if we need to kind of look at other options. So, assessment of the safety and responses Wegovy in MASH patients is mainly, like I said, for moderate to advanced fibrosis, which is the F2 to F3. The other treatment option we have is Rezdiffra. This one has been around for a while. Well, recently too, it came around, I think, 2023. It can be considered in patients with MASH with F2 to F3 fibrosis as well. The recommended dosage is 100 milligrams per day for people who weigh more than 100 kilograms, or you do 80 milligrams for people who weigh less than 100 kilograms. But if you're using it with a cytochrome P450 2C8 inhibitor, such as Plavix, the recommended dosage is 80 milligrams per day for persons who weigh more than 100, or 60 for people who weigh less than 100 kilograms. So, as talked about previously, Rezdiffra is not recommended in people with cirrhosis, basically, whether it's compensated or decompensated, or anybody with autoimmune hepatitis, or anybody with PBC, or anybody who's continuing to drink heavy alcohol use, considered more than 30 grams a day for men and 20 grams per day for women. So we use this because it acts on the thyroid globulin receptor. You want to make sure you do thyroid function assessment before starting treatment to make sure that thyroid levels are under control because it acts on the same receptor. And so for people who have untreated hyper or hypothyroidism, you want to make sure that they're seen by you guys or endocrinologists to make sure they get their symptoms under control before considering starting this drug. Most of these drugs, they all cause bad GI side effects. Most people, when they started this drug, they get really bad diarrhea. It typically gets better over the course, but they get really bad diarrhea for the first 1 to 2 months, and then it starts to get better. So that's common that we see with this drug. They also can get gallstone-related issues too, such as cholecystitis. So when you start people on Rezdiffra, you want to get hepatic function panel testing. You should order it before you start, and then you should order it in months 3, 6, and 12 to determine the response. Because this medicine can also cause hepatotoxicity, ideally, kind of in some people. So you just want to make sure, because you start noticing any elevation of their liver enzymes, you may want to stop this medication. Right now, since it's so new, they still haven't really made a recommendation if you need to continue monitoring a hepatic panel after 12 months. But they suggest if you're going to check it, at least do it every 6 months after that first year. And like I mentioned previously, people who have known thyroid disease, you want to make sure you take their TSH and free T4 per the guidelines. And I have a chart that's coming up, what they typically used in the trial before they started this. And then you just got to be careful too if people are on statins, because this drug can cause a DILI and statins can cause a DILI. You want to make sure that you adjust the dose of their statins so they can only be on a atorvastatin 40 as a max dose, pravastatin 40 as a max dose, rosuvastatin 20 milligrams as a max dose, and simvastatin 20 milligrams. That's the max they can be on if you consider starting this medication, because you don't want to cause further liver injury. So this is just a summary of the Rezdiffra. So it's mentioned it's not recommended in patients with cirrhosis who have liver stiffness measurement greater than 20 kilopascals, or MR elastography greater than 5. Anybody who has active liver disease like hepatitis, heavy alcohol use, and anybody who has active thyroid disease that is untreated. It's recommended in people, like I said, have the intermediate score on FibroScan, such as 8 to 15 kilopascals, and the 7.3 to 9.8 on F testing, or if they have a biopsy and it shows F2 to F3 fibrosis. And it can be used for people who have ranges outside of the common things, but it takes like a multidisciplinary team to go over it together with everyone to see if what would be best for the patient. So for Rezdiffra, so before, like I said, starting treatment, you want to get a hepatic panel on these people, you want to check their thyroid function, you want to get a lipid profile, and you want to do non-invasive testing, whether that's F testing or FibroScan. And then you consider MRI PDF, that's just testing to see how much fat's in the liver. We don't do that here though. At 3 months on this drug, you want to check the hepatic panel again, and then at 6 months, you want to check the hepatic panel, thyroid panel, and the lipid profile again. And at 12 months, you do everything, and you repeat FibroScan to see if they had any improvement. If they haven't had any improvements, you can consider continuing it or discontinuing it just based on patients and the side effect profile if they have any side effects associated with it. So this is, like I said, it's just another thing. So let's say if they have worsening non-invasive testing or consistent increase in the ALT, or that means they have no response, you want to stop the medication. If they have improvement in their liver stiffness measurement by greater than 25%, when you do repeat it in a year, it's shown as beneficial, you can continue it. If they have minor reduction, this is something you can talk about with the patient again, based on the side effect profile, if they want to continue it and reevaluate again in another year. So this is just showing basically that MASH is a multidisciplinary thing. So you have to make sure they're following with the endocrine, primary care, nutrition, make sure they're doing all the things for lifestyle management, kind of like even seeing like if they have anxiety, stuff like that, following with psychologists, psychiatrists in the outpatient setting. Cardiology, making sure they get their blood pressure, lipids under control, and weight management as well. It takes a whole team, a whole thought just to kind of help these patients. So basically, in conclusion, optimal care of patients with MASLD requires, like I said, a multidisciplinary approach. The majority of patients are in a primary care, you guys setting. So the most important things is making sure you're doing the field fours, getting their diabetes under control, their lipids under control, their hypertension under control, weight loss, all that stuff. The role of the gastroenterologist includes more comprehensive liver risk stratification. So these are the people, like I said, with the really high FIB4s greater than 2.67 are kind of concerned for cirrhosis on imaging with nodule appearing or low platelets. Like I said, all patients should undergo dietary nutritional assessment and plan for established regular follow-up independent of the gastroenterologist, which you guys see all these patients, y'all see them. The need for more specialized obesity management, including bariatric surgery referral, health psychology, and additional cardiology or lipid metabolic support should be assessed on an individual basis. So the big thing I just want to remember that weight loss works, right? So like I said, greater than 5% weight loss will improve steatosis. Greater than 7% weight loss will improve inflammation associated with the fats in the liver. And then greater than 10% also can reverse the fibrosis if someone's on that borderline F3 and close to getting cirrhotic. If they lose more than 10% of the weight, they can actually reverse it and prevent from becoming a cirrhotic patient, which is life-saving for these people. So remember, MASLD is not a liver disease. It's a hepatic manifestation of a systemic disease, as we all know, is metabolic syndrome and obesity. So it's really not a liver disease. It's dealing with this new metabolic complications from people being overweight, diabetic, uncontrolled blood pressures. And these are my references. So any questions? Yes. Right here.
Let me see. We had a hand over here first. But you're far away. It's okay. Here you go.
So this question isn't necessarily about the MASH, but it's more about cirrhosis and the choice of an NSAID over Tylenol.
No NSAIDs.
Well,
Tylenol, no more than 2 grams a day.
Yeah, because when I first got into practice, it was Tylenol bad for liver, bad for liver. But then I found out that because of the NSAIDs, it's the platelets, it's the clotting.
Well, that and the gastrointestinal lining, most of these people have varices and stuff, and they get really bad GI bleeds. So it's just for that reason as well, cause just for the inflammation it causes on the gastric lining, and they can bleed out. Yeah.
No more than 2,000?
No more 2 grams, yeah. A day.
Okay. We'll continue this table. We'll get to you, Jackie.
I've been out of practice for a little bit, but when I was first practicing, there wasn't anything for these MASH patients, and I was in rural family practice, tons of these patients. And so I was doing a lot of, rogue stuff. What can I do? I have to give these patients something. And I found in my research vitamin E. And do you have any thoughts on vitamin E supplements on these patients? I was doing that and then GLP-1s before we had Wegovy. So
I mean, it hasn't been much anything. It doesn't hurt, right? Because you used to use vitamin E beforehand, but nobody's really recommending that anymore. But I mean, vitamin E doesn't hurt, so we still give it to some patients. If they have been on it and continues taking it, it's not. We don't stop it. So, but there's no evidence now recent that shows any benefit.
Okay, does this work? When you do the FIB testing, I was just, do you do it on kids as well? Because, a few years ago, I still see kids that are overweight, high blood pressures, pre-diabetic, all that stuff. So at what age do you start doing these FIB tests? And is it covered by insurance?
So you want to do it older than 35, right? Because if they're less than 35, it can be inconclusive. You just want to make sure that you get there. If you start noticing they're elevating their liver enzymes, I would recommend sending them to a pediatric gastroenterologist to make sure they don't have any other thing that's developing, because there's a lot of things, younger kids, liver diseases that they can get. So they want to make sure they check for those and they don't have them. But you have to just continue lifestyle modification in these kids, like losing weight, getting their diabetes under control. But yes, typically, I don't know if insurance, it's just a calculation that you put in. It's just a dot, it's a dot phrase. It does it based off their PTINR level, platelets, ALT level as well. So that's all it includes. So you can do it based off lab work. It's just a calculation. So insurance shouldn't really cause for the field for you. Maybe talking about the FibroScan. Yeah, so I don't know if they would, kids, since I don't deal with kids, I don't know if insurance would cover it. But I'm sure the pediatric, when we referred to them, they would know if it was covered or not.
We have a question over here.
Thank you for your presentation. I enjoyed it. Could you tell me how much the medication costs to treat this? It's a once-a-day pill, but being that it's new, what's the cost and does insurances pay?
I don't know. We never had any problem with cost. Insurance covered it where I trained, so no patients ever complained about the cost, so I haven't heard anything.
It's tons.
Well, I've seen these people at a rich hospital in D.C., so, they had to get insurance, so. You never had any problem. Because everybody else was on Wegovy, they were on the GLP-1, but the people who did get on Rezdiffra, they were from a higher income. Yes.
Anthony?
Have you seen a case where the KPA levels don't necessarily match as well as the ELF blood levels? Or are they pretty well
They're pretty well accurate. Only time it'll be off is people who have ascites. Most of these people are cirrhotics anyway, so you don't do it in people who have any ascites because it'll make the numbers be off.
Don't do the ELF blood test?
No, that'd be for the FibroScan. So if anybody have ascites, it'll make the number be off. That's the only time it's been inconcordant. But there are a few cases, and if that's the case, you can send them off for the MRI elastography. But very rarely.
You said we don't have that. Is there one available nearby?
MUSC does it. Okay. Yeah. So.
Anyone else?
To your knowledge, has the oral Wegovy shown the same benefit that the injectable does?
It's funny. The drug reps are coming to talk to us. I mean, it's not proven yet, but they're trying to say it does the same, but we don't know. Like, it's no trials that's been going on long enough to say. But they are saying that it should, but I don't, we don't have the evidence of that yet. But they're trying to push it, yes.
Is it working because of weight loss or for some other magic?
Mainly for weight loss. And then, like I said, because it's, it fixes sleep apnea, everything. So that's just like the magic drug. So it's getting all the metabolic risk factors so that it helps the liver because you're getting rid of all the metabolic stuff that you have going on.
Dr. Lyons?
Does anyone have a tip or trick to get Wegovy approved for this? Because I literally just wrote a letter yesterday.
We'd get it approved, but it has to be, it can't just be fatty liver.
I had proven FibroSure and 2 fibrosis, and they said, no, thank you.
No, they should.
Probably the insurance.
They do, yeah, because the rep come by and she gives us a thing. I can see if I can find it and send it out, but they cover it. They have something that what you're supposed to put in there to get them to cover
Oh, I
it.
had everything in
you
there.
did?
I've talked to the rep before, and it was commercial insurance, and they said no.
That's strange. I don't know.
It just may be those insurances, there are always those one-offs.
I was going to ask a question, but before I say that, remember that the GoodRx price for oral Wegovy, which does have similar bioavailability, which I think is the basis for the claim that it would work, is $140 a month. So it's probably more affordable. What about tirzepatide? Do we know anything from studies or anything like that?
Nothing, no. Only one so far is just Wegovy.
Just
Nothing-
semaglutide.
Yeah, that's semaglutide. So
Anyone else?
it's someone at the back.
With resmetirom is $50,000,
Well, there you go.
So it's horrible, And you mentioned that lifestyle modification is,
So-
as good. Yeah. So why are we spending $50,000, dollars? And is there any comparison of Wegovy versus resmetirom?
So, they both show improvement. It's nothing that they both work the same. One's not better than the other, but Wegovy is a cheaper option and less side effect profile compared to Resdifra because these people can get, like I said, dillies associated with the medication. And sometimes the diarrhea is really bad that they have to come to the hospital and get admitted for dehydration. So some people can't even get past that phase of the diarrhea, so they end up stopping it pretty early. I'm sorry, I can hear you.
As far as efficacy, there's comparison.
No, they're not comparison. There are no trials comparison the two drugs together, not as of this point. They're probably going to start it soon now.
Okay, any other questions? All right, we're going to just take a short pause to change out the microphone, and then we're going to move on to our next speaker. Dr. Pinto is going to speak with us about heart failure.